Colleagues and friends, welcome to Copenhagen and welcome to the international meeting on type 1 diabetes, held under the title, and please remember the title because that's what we are going to do, Advancing a Global Road for Improving and Integrating Care in Low-Resource Settings for Type 1 Diabetes. It's a very important task.
What would be very important today and in this conference would be the country perspective. And most of all, the view of the health authorities in the countries that we are discussing in this meeting.
So I think all of us in this room today are aware that the global burden of diabetes is rising. WHO estimates from 2017 showed that 9 million people were living with type 1 diabetes, or 2% of all cases at the time. And this represents a small but vitally important proportion, impacting millions of people who rely on continuous access to insulin, care, and support to survive.
We know that type 1 diabetes, historically, mortality has been high, but what we were trying to look at is in that particular project was even with insulin access coming through this different insulin scheme, if you look at mortality, certainly it has reduced, but we don't have hard data from what happened 30 years ago.
Every single human being on the planet deserves to access healthcare that is accessible, affordable, and without any financial hardship. And we all know where we stand. More than half of the world's population cannot access the healthcare that they need to get. And it's the same with people living with type 1 diabetes because it's a chronic long-term condition and it's not, that you just medicate and that's the end of the story. We are living with the condition until the end of our lives.
All authentic patients had an access to type 1 services, and it is only in one region at the tertiary facilities. But thanks to the support from our colleagues, WWF, Life for a Child, CDIC, and other colleagues who are working with us, we managed now to increase number of sites from 1 to 83, covering all regions in Tanzania. At least all regional referral hospitals had type 1 diabetes clinics. Initially, this was a TDA and WWF-led initiative, but at the moment, it is a national NCD program owned by the government.
My name is Christine Nabatazi, a warrior coordinator, Ginger Type 1 Diabetes Clinic, Ginger Regional Hospital. I'm here to talk about type 1 diabetes country perspective, Uganda. Type 1 diabetes should never get in the way of a child's dream. Thank you for this opportunity.
At Africa CDC, we take this issue around improving access to insulin, access to treatment for type 1 diabetes as a very important issue. One thing that was striking my mind was we still talk about promise. Promise is a commitment, and throughout I've been hearing commitments, political declaration, but how do we move from those commitments to mission, to action?
I've talked to so many ministry officials and the government people. Many do not really understand the difference between even ministries of health. They do not really understand the difference between type 1 and type 2 diabetes. That's one thing that I think really needs to change.
What is actually being provided to the person with type 1 diabetes, and it is that last mile whereby you provide the care and the treatment, but at the same time provide all the commodities which are required.
Point you raised, of course, as policy level, one of the issues is to understand the context of the local population and health service delivery. In other part, it's very important also to lobby the global community and to bring the attention at higher level. As member state, we are that privileged to share the experience and also to make noise at higher level.
Non-communicable disease burden in Bangladesh, around 71% of the death is related to the NCDs.
We are currently in 30 countries. collaborating and supporting local partners, diabetes associations mainly, but other also different NGOs in different settings or individual clinics across approximately 600 clinics, supporting currently 65,000 children that we reached on a monthly basis.
I was 26 years old young adult, when I was discovered with type 1 diabetes. Usually, people or individuals with type 1 diabetes are being forgotten.
So one of the greatest barriers we see is that our supply chain is really weak. And there are a number of factors that are responsible for this. First of all, we have poor demand for forecasting data.
It is determined on the local partner. We need someone who is passionate and dedicated to caring for young people with diabetes. There's many passionate and dedicated people in the health service in the country, but they need to be passionate about type 1 diabetes, and we have that in the countries where we help. Frankly, I think things have gone backwards over the last 5 years with COVID and then the inflation that happened post-COVID, which is still happening. Sadly, I think we've gone backwards in provision over the last 5 years.
What we have to do to change the type 1 diabetes scenario in Brazil? Ameliorate access and treatment adherence, management and dispense of medicines and supply near the house of the patients in the primary health care, because some patients doesn't have the money to transport to the reference centers.
Community engagements, advocacy, involvement of traditional chiefs, schools, religious leaders, other stakeholders such as civil societies. It should be made clear that children and adults with type 1 diabetes should never be stopped on insulin treatments, regardless of religious beliefs or any social affiliations.
Access to care or access to insulin for the people with type 1 diabetes, we have to differentiate these two things, as because access to insulins or the monitoring system for the type 1 diabetes is the human right.
First is to integrate it better at the level of the primary health care. Second, to improve the coverage of comprehensive care for these patients, whether for outpatient level, inpatient, and also to integrate the psychosocial, and also at the level of the supplies and the medications, they should be covered. To add human resource capacity at the primary healthcare level that is needed to provide this multidisciplinary approach, whether psychologists, social workers, nutritionists, and at the same time encourage the task shifting, specifically building the capacity of nurses to become health educators in a way, or community health workers also that can play a role there.
It is wonderful to hear about the progress in different countries, and I'm very impressed with the countries that presented here before me. The integration, how they are using technology also to make it so more accessible, more available to the population. So from apps to drones to deliver to mobile van and different strategies.
I was working as a maid and I lost my job. I was returned home where I was isolated. I was seen of no use because they thought I'm dying soon. A local NGO started supporting me because I was doing well in school, and I was able to get my teaching certificate. After my teaching certificate, I have been able to continue with my education through SNF's scholarship program for my diploma in special needs education. I am now a warrior coordinator at Ginger Clinic Hospital.